Oh, we keep going with head and neck frozens. And so it'll be the same format as before. We've tried to sprinkle in kind of common themes and intraoperative questions followed by sort of, permanent follow-up in IHC, sort of same as before. So yeah, without further ado, shall we? Volunteer. Liza's gonna go. Yeah, I see it. I see the itching in her bones. History. Oh, I have. Thank you. Hope everyone had a good weekend, by the way. All right. While you get yourself organized, this is a 67-year-old female. Yeah, and you can look at either screen. They're both up, right? With a parotid mass. And as we go through these, we'll talk about what they're looking for with salivary gland frozens. We see them on occasion. We don't see them always.
We'll start as it comes for the frozen. If we have the entire tumor versus if we have only a chunk of it, that will show us that if it's well circumscribed or not, how the cut section is going to look like. If it's mucinous, gelatinous cut surfaces, or like more mahogany, more nodular. So this is a nice cut frozen section, I would say. And we do have, which is making me think that this is something that is confined. And on lower magnification, something malignant is not popping out for me, but we'll go down and see.
That's very out of focus.
Oh, sorry. There. Some areas that looks like your back, or areas that might have some secretions and now they're empty. But it does look more like fat, and then there are these glands now. Again, they look great to me. Some secretions in them. There is some dimorphism in the nuclei. The nuclear chromatin is kind of soft.
It's about those ducts, duct-like structures. Cell layers, yeah.
Yeah. And then for the 2 cell layers, there are certain things that comes in mind. So very nice.
Yeah.
And if I would have a cytology specimen, some full hair, maybe I would want to call it something. Yeah, so a low grade neoplasm favor pleomorphic adenoma.
So yeah, we can talk about, what they're, well, look at the permanent, and then we'll come to a discussion.
Decent. Here we have, so we have the 2 layers of cell. And then that myxoid kind of stroma in the background. And it's low grade because I don't see that many mitosis, there's no necrosis, yeah, although there is certain level of dimorphism on them, it's still very low grade.
Yeah, so between for salivary gland tumors, between low grade malignant and benign, the cytology doesn't always necessarily help you, right? Because low grade malignancies can be very bland appearing. So the most important thing for then benign is gonna be essentially the circumscription, right? So can we take a look at the periphery? I don't know if this is the frozen remnant or is this a,
I give them the rest.
It's a different section,
This is the frozen.
okay, fine,
but then you do have like this nice,
pushing border.
it's pushing, but it's still like respecting
Yeah.
the rest of it.
Yeah.
That's a little iffy, but that's still, the lesional tissue is very different from the nearby salivary gland, so.
Right, right.
There's no question on. Because invasive slash,
Looks to have at least focally a capsule, very well circumscribed.
Yeah.
Pleomorphic adenomas can have these pseudopod-like structures that sometimes project little tongues into the adjacent gland, so that's not totally uncalled for, but a little bit of blurry. There we go.
that maybe here, like a little bit of tongue coming out,
Right.
but then.
But that's okay. That's
Yeah.
okay. Okay, cool. So, you know, you're more often than not, right, a salivary gland tumor, if you statistically, if you just take chances, you're gonna find a pleomorphic adenoma, right? Because it's the most common tumor. But what I wanted to bring up a little bit was how go with this on frozen. Can you, oh, let's see. I need you to see, hold on one second. Let me know if you now see the whiteboard. Yeah, okay. So I want to talk a little bit about how we approach Frozens for salivary gland tumors. So, you know, as Faiza was saying, you know, sometimes you might get a snippet of a margin, and sometimes you'll get the entire tumor for frozen. And so when you're getting a snippet of a margin, mostly it's just, is there tumor or is there not tumor, obviously. But if you're getting an entire, you know, resection of a parotid gland with, you know, a tumor in it, with some kind of cytology, usually there's some kind of cytology diagnosis, right? What they essentially want to know is not even, is this benign or malignant, but even more easy, is this high grade or is this low grade? Low grade being benign or low grade carcinoma, because they will do a neck dissection for high grade and they will not for benign or low grade carcinoma. So that's mostly what they're looking for. We've been looking at correlating the FNA diagnoses or the core biopsy diagnoses, because sometimes these come as cores, to the frozen and to the final. And like pretty much most of the information is there on the FNA. Like, so there's not a lot of information that is being gained at the time of frozen. If it's called a PA, it's a PA. If it's called a Warthin, it's a Warthin. If it's called low grade, it's low grade. So you can use that to your advantage, but really that's what they want to know. If you can make a definitive diagnosis, awesome, like pleomorphic adenoma. If you can't, as long as you tell them it's low grade or high grade. And so the way that you treat these, unlike the mucosal ellipses where you really have to cut every single section and look at it and look at what's closest to margin, right? Because that's what they want to know. For these, unless they're looking for margin status, which usually they're not, they're just looking for grade. Most often I advocate just making sort of one cut through the tumor to allow you to expose the face, to allow you to take one section, but preserve the integrity of the capsule at the rest of the lesion, because that's going to be important. And kind of like thyroid, right? We don't really freeze thyroid for similar reasons, because you destroy the integrity of the periphery. So similarly with salivary gland, I would advocate maybe usually just taking one section kind of down the center, you know, freezing one of these and just leaving the two caps intact and sort of, you know, fixing them I think the instructions are in the gross manual, but fixing them pinned down, kind of like they do for prostates that get tissue banked, so that you preserve the capsule and the face of the tumor. So once you have your center section for freezing, and your two caps, the other thing that one could do if interested is take a smear or a touch prep from the exposed cut surfaces of the tumor. So how many of you have done smears or touch preps, not for neuro cases, but for tumors? Yeah, okay. So how do you do it? Like technically, what method do you use?
So there are two ways of doing that. Either you just like face down, you just blot it on
Right.
the slide, let it air dry. And if you think that it's not coming off, the cells are not coming off, then we can take a very small piece of tissue
Mhm.
and try to smear it along the slide and then let it air dry and then stain it.
Yeah, cool. So true touch preps where you touch the cut surface of the tumor on the slide, right, are really good for processes that are discohesive, like lymphomas. Processes that are cohesive, like epithelial tumors, or processes that are embedded in a lot of stroma, right, like mesenchymal neoplasm, have a harder time just coming off onto the tissue. So in that case, and we've done this, some of us together, you can take after you've blotted off the blood and the mucus or whatever's there, you can take a scalpel blade and scrape the surface of the tumor, plop that down on the slide, and then smear that with a second slide. So it's more close to an FNA where you're actually trying to get cells out, place them on the slide, and then spread them, as opposed to just plop. Does that make sense? So when we are in the growth room together and we have a fresh specimen, we can try that technique. But for cohesive epithelial things, that works pretty well. And it allows you to get a better impression of the cytology, because sometimes frozen can introduce artifact, like ice crystal artifact, right, into the nuclei. And if you do a smear, you're not freezing it, so you don't have ice crystal artifact. What I do with those smears, you can air dry them for diff quick, like for lymphoma workup, or you can immediately place them in the alcoholic formalin like you would for a cryosuction, like the little white jars, right? You can immediately place that smear in the alcoholic formalin for fixation, and then stain it with H&E, and then you get perfect, crystal clear, like beautiful nuclear morphology. All right, so those are the processes that I would advocate for fresh tissues and tumors. Does that all make sense? You guys have comments or questions on that?
Do you do this for every specimen?
I do this for specimens in which I have the obvious face of tumor, right? So I'm not going to do it for margins or little tiny ditzels, right? But if I've got a tumor, yes, I'll do it.
Workflow purposes, if you do these touch preps, you just like print out a sticker for them and keep them in the case? Or?
Yes, I print out a sticker with them. Just scratch out, or you can cross off the thing that says cryo and just write smear or touch prep or whatever, and keep them with the case. You can, I think, you can actually bill for it. I think the techs might have a way to charge for cryo and smear. You can always bring that up to them, and they can add in a protocol for a smear, but it won't necessarily print out for you a different label. So yeah, just print out the regular label and keep it with the case. It's most important. Oh, sure.
For the, you could either do it like the display route, or you could do that on formalin and alcohol.
I usually don't. The cytologists like it. So if you're with like Antich or Jeff, they like DiffQuick because that's how they're used to assessing immediate adequacy in cytology, right?
Like a comfort or familiar.
Yeah. For me, it doesn't, like, I'm looking for specific nuclear morphology. So for me, nuclear morphology is better on a fixed procedure like a PAP or an H&E. But they're used to it, they're just used to the DiffQuick. So I don't really do this. unless you have unless you have time and you want to experiment, like cool, like that's fun. But if you're in a time constraint, you don't have to let it air dry, H&E's faster, like, so, yeah. Okay. Does that all make sense? All right, so I will stop this. Oh, fantastic, that's fantastic. Okay. All right. Awesome. Okay. All right, I think you guys now see the screen and you can see the screen. Okay, I think that's right? Can somebody put a slide on there? We'll make sure that's the microscope. Yep, perfect. Okay. Okay, who's next? This is and we are going to talk about the differential diagnosis of salivary neoplasms, certainly, but I do have pre-recorded like didactics on this. So you can I can send you out the links, or you can just find it, on the YouTube. They're all there. So I feel like rather than repeating some of those older lectures that haven't really changed much, we do something that's a little more interactive.
In low power, we have a relatively well circumscribed lesion that's pretty hypocellular.
Like it's still blurry.
Is it?
Yeah.
Blurry.
Maybe you can adjust the eyepiece to the screen.
We've tried that. It's really friggin' hard.
Um,
But sometimes you just have to,
Yeah. It's pretty good now.
It's good
yeah.
now.
Just to repeat what I just said, I think we have a relatively well circumscribed hypocellular lesion with pretty myxoid background. See these hypocellular myxoid stromal areas, some cells. I feel like these are more like ducts that are cutting tangentially, I think, on the center piece. And I see maybe 2 cell layer. General, I personally think that's low grade, for to decide low grade versus high grade. And given basically combining the fact that it's relatively well circumscribed, it has these so kind of biphasic appearance of these smaller ducts. I think this could be another PA.
No. Oh, so PA can have a very, very varied appearance, right? In some cases, like the first, a little bit more cellular with more prominence of those nice bilayered ducts. In other areas, much more stromal, right? Like this, where you get only occasional cells. And interesting, look at, is this as low power as you can get?
I can go.
Yeah, okay. So this focus, or am I just,
Pretty good now?
yeah,
Okay.
better. This is kind of interesting, right? Because one, it's very stroma rich, and you can see that the focal cells within the stroma. Two, if you go around, it looks to be still on low power. It looks to be almost modulated, right? There's like bam, 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 and then you have normal salivary tissue, right? And then you have more tumor on the other side. So what are you thinking with this low power architecture? Because you already saw the cytology was super bland, right? It's got this nice chondromyxoid stroma. Like this all kind of fits for PA. Like what's it doing? Why is it like this? Maybe.
The secondary, like it's
Yeah, it certainly raises the possibility that this is a recurrence and a secondary excision with this sort of multi-lobulated, I almost like to say kind of buckshot, right? Like shattered, scattered little globules or nodules in the stroma. I don't know. This is all right. The 69-year-old female with left parotid gland mass 1.2 cm on MRI. Do we know if this was a recurrence? Yeah, so it's interesting because sometimes patients come with a history of prior surgery and sometimes they don't. That doesn't mean they haven't had it, right? But this has actually been, for those of you who are taking boards, right? This has been a board school question where, sorry, it's really warm in here, where they show you this appearance of this multiple lobulated pleomorphic adenoma, and they're like, what was it? What was in the patient's history? You know, and it's like, this is a recurrence. Like the answer is this is a recurrence because of the fact that in their native state, PAs don't necessarily have a high likelihood of growing in this fashion. And so when you see this buckshot type of pattern, it's essentially 99% of recurrence. Whether or not they have the history of a prior excision or not, I would vote that would be the case. So because the pseudopods or the lobules that we can see in a native PA usually aren't quite as geographically or architecturally like extensive like this, right? They don't ramify, they just like poke. But when they ramify like this, it's generally because it's been seeded from a prior procedure. Okay.
So a lobulated, or like the one that has its tongues out is not gonna look like lobulated at all.
Right, it's just gonna look like, it's still gonna be connected, like just gonna be like, bloop, right, or like, bloop, or like,
that.
yeah, like a
that
little
and-
thing, right? When they're like now completely separated, like by distance of stroma, that's a little unusual. That's a little unusual. And separated by normal gland, right? All this stuff is becoming to be a little bit more suspicious. Sometimes they recur at like really extensively in a diffuse kind of small nodular pattern throughout the neck. And so if you think about parotid, right, tail of parotid level 2 tail of parotid can dive down into the neck into high level 2, right? So sometimes when you read the words level 2 or tail of parotid, those can be interchangeable. Once you start getting down to like level 3, level 4, level 5, like no, but high level 2 and parotid can sometimes be interchangeable. So don't necessarily think that they're like, oh, I'm in the lateral neck. It can be if you're high. If that makes sense, just to think about the anatomy there. I know we're getting a little bit complicated, but
I have a quick question.
yeah.
So compared to this occurring as a malignant transformation versus it being kind of like this case, apart from the cytology feature, it's high grade versus low grade.
Yeah.
I kind of see the fat and surrounding salivary gland as being happy there.
Yeah.
It's like happy. There's like no reaction to it.
Right.
Can that be a like clue that can help us spy whether it's benign or malignant?
Yeah, that can be a clue. So there's no desmoplastic reaction.
Okay.
There's no like sclerosing, like infiltrative growth pattern. This is all very well defined. The only problem that we have seen with transformation or differential diagnosis of malignancy in this type of neoplasm that has a chondromyxoid background is the differential diagnosis between a stroma-rich pleomorphic adenoma and do you happen to have that case? And a pure like myoepithelial carcinoma or an epithelial myoepithelial carcinoma that is invasive in a kind of lobulated fashion. Can you grab it? So this is a really important point because we had a recent case that controversy over whether it's a pleomorphic adenoma, a carcinoma ex pleomorphic adenoma, or a de novo like myoepithelial or epithelial myoepithelial carcinoma because of the lack of a desmoplastic stromal response, and the presence of a pushing invasive lobulated border. So, but the tumor is metastatic, right? The tumor is like metastatic to the lung. Like, so whatever it is malignant, then the question is, how do you determine that it's malignant based on just the H&E original morphology? And so when she brings the case, we can get into it, but that is the one exception to this rule in this differential diagnosis, where you can have not high-grade cytology, not a desmoplastic reaction, but there are other clues within the native body of the tumor that allow you to suggest whether it might be a benign or malignant. Those are pretty rare cases. Oh, that was fast. Here, can I grab this one?
Sure.
Unfortunately, this is only a few sections because it's an outside case, so it was sampled not extensively. This is one. So in this case, you have a similar pattern of stroma, right, with this kind of myxoid or chondromyxoid stroma. You have these relatively bland-ish cells in the stroma without significant pleomorphism or mitotic activity. What you effectively see as a growth pattern, right, again, is this sort of multi kind of lobulated appearance, occasionally with accentuation of the cellularity. Occasionally with accentuation of the cellularity at the periphery of the lobules, which is not something that is characteristic always for pleomorphic adenoma. So for epithelial myeloepithelial carcinoma or myoepithelial carcinoma, the low power architecture can be somewhat similar, but with the presence of cellular accentuation at the periphery of the lobules. Sometimes if you're lucky, you'll see necrosis in the center of the lobules, but not always. But this kind of loop, right, with higher cellularity at the periphery. What you're missing for pleomorphic adenoma is you're missing necessarily that abundance of bilayered ducts. You're missing, you can draw a line between, well, what's chondroid and what's myxochondroid. If you see fully predominantly myxoid, that could be anything. If you see fully chondroid, that tends to push you more into a pleomorphic adenoma rather than another. But arguably, well, what is this? Is this chondroid or myxochondroid? These are starting to look almost like lacunar type cells, but this is really few and far between. And this was a tumor that ended up metastasizing. And on the outside, it was originally called pleomorphic adenoma, and then it metastasized. And then they took a look back at it and were like, oh, I guess it's a myoepithelial or an epithelial myoepithelial carcinoma. And like, this can be really hard. What you don't have, right, is you don't have any normal salivary gland tissue on the side, on the side to tell you whether it's infiltrative or not. But often these types of carcinomas don't have a super like blow through infiltrative pattern. They have, again, this more like rounded, lobulated, pushing infiltrative pattern. So this can be really hard. And that's why sampling of these is super critical. And I see what, 1, 2, 3, 4, I see six sections here. I don't know how big this tumor was. Like 5 centimeters and 6 sections. Like, honestly, that's not enough. So when we have you guys submit your salivary gland neoplasms, we basically say, right, if it's 4 centimeters or less, just submit the whole thing. If it's more than that, submit like extensively, right, like at least 2 sections per centimeter. So I would have expected like at least, 10 plus sections from this, because patterns can be overlapping, invasion can be hard to find, things like necrosis, et cetera, can be hard to find. And so you really need extensive sampling in order to sometimes make a distinction between benign and malignant cases. And this is one of them. I think it was probably undersampled and underdiagnosed before it was realized to be ultimately metastatic.
I was gonna ask that was like the original, like not like the afterwards?
No,
like,
this was the original. Mhm.
Did you see the metastatic focus?
I don't
Did you-
think we
sorry.
got the metastasis.
My question is, because due to the undersampling, we may have, like, could it be that they missed to gross the area that's high grade? Because, I don't know.
So. Myopithelial / myopithelial carcinomas, I'm just gonna lump them together because morphologically they're really similar. They don't always have to have traditional high-grade morphology to metastasize. Most other salivary gland tumors do. Salivary duct, adenoid cystic, like most of them have something. Pleomorphism, necrosis, mitoses, PNI, LVI, most of them have that. These, for some reason, are like the sleepers in that category. Like this is a common problem in salivary gland neoplasia is these epithelial, myoepithelial / purely myoepithelial carcinomas in terms of the lack of overt high-grade features and still being able to metastasize. This was brought up at a USCAP meeting like a number of years ago. It was one of the case discussions. It was exactly like a similar issue, right? So this isn't, it's well known, and that's why like caution should really be exercised when you have something that isn't 100% certainly a pleomorphic adenoma, or is large, or doesn't have an abundance of those nice ducts in them, right? Like, just exercise a bit of caution, submit extensively, and do the best you can.
What's the size of the metastasis?
What?
Is it conventional?
Was it lung? Its true nature only became apparent after metastasis develops. No, I'd have to check the, it might have been lung. I'd have to check the notes, but, yeah. So there's also this concept of a quote unquote benign metastasized pleomorphic adenoma. I now don't even know that exists, because maybe it's not a benign metastasizing pleomorphic adenoma. Maybe it's just an underdiagnosed low grade, epithelial myoepithelial carcinoma. And now the only way that we have to sort these things out a little bit is genetics, right? So we know that pleomorphic adenomas have rearrangements of PLAG gene or HMGA2 gene. Epithelial myoepithelial carcinomas, if they arise from a PA, retain PLAG. So you'll never, like that transformation, you'll never be able to sort out genetically. But if you have genetics that are unique to a certain tumor, like I think we've discovered like HRAS in some of them, in some epimyoep carcinomas, or EWSR in the purely myoepithelial carcinomas. There are some of those genetic anomalies that do not occur in PAs, right? So if those occur in one of these tumors, you know that it's not a PA. But if you have a PLAG, that doesn't necessarily tell you it's benign or malignant. That tells you it came from a PA. That doesn't tell you whether it's a carcinoma X or not. Does that make sense?
So if like you told them there was something with the capsule, like it was pushing out, etc.
Mhm.
Like initially, if it's a PA, they're gonna do like a partial maybe parotidectomy or take the whole thing out. But if you told them there was like capsular involvement or something, what would they do? Like,
So they're always gonna take the whole tumor out.
right. So I guess like what would have been done differently in this case? Like it would have been called like myoepithelial.
Oh, in this
You know
case,
what I
if it
mean?
were called carcinoma,
Yeah.
they would have asked for a grade, right? So you would have had to grade it.
Okay, and then.
And
maybe-
then if it were low grade, they would just do observation.
Yeah.
And if
got
it were high grade, they'd do a neck dissection plus or minus chemoradiation. So maybe, but even if you called it a PA, they still monitor these patients closely because of the risk of local recurrence anyway. Now that it's popped up in a metastasis, the treatment algorithm is going to change. They might give systemic therapy, right? But honestly, potentially no harm was done in this case, because even if it were called a carcinoma, and if it weren't called high grade, they would have just observed anyway. It's like in retrospect, you know, unfortunate because we want to be right. Like we want to be right. We want to do what's best for the patient, but sometimes it's not always obvious.
That maybe semantics, but like for the benign metastasizing PA, which may or may not exist, does the Kaplan-Meier curve look different from like one of these true, like accurately diagnosed carcinomas that would net out?
Like behaviorally,
behavior that, like, is
so
there clinical-
yeah, the quote unquote benign metastasizing PAs, you know, just like benign metastasizing leiomyomas or giant cell tumors of bone or whatever, like most of the time they are still cytologically bland, not aggressive, low grade, and don't kill the patient. You know, it's like are these low grade metastasizing carcinomas? Are these multifocal tumors that are popping up that we just haven't had the ability to analyze clearly enough and say, oh, these are actually multifocal primaries? And I mean, some people have done that and been like, because you can get a pleomorphic adenoma in your lung, right? You can get an adenoid cystic carcinoma in your lung. Does that mean it's a metastasis or a new primary? Well, if it had, you know, these are the things that we haven't really sorted out yet. And so like the prime example of this that we think we know is, help me out here. Oh, epithelioid hemangioendothelioma in multifocal. I believe that genetic analyses of multifocal epithelioid hemangioendotheliomas have been done. And I can't remember what the conclusion was, whether they were multifocal primaries or metastasis, but it's in these kinds of cases that like, that's the only way for us to really understand what the biology of this is. If anybody wants to find out what the conclusion was on EHE, that would be an interesting thing to know, because I what else? This is case 2. Case 3. Okay. You need this adjusted.
Sorry.
We can do that one. Right. Right, but does that mean it's metastasis or multiple primary? He found variability in the human transcripts and multifocal EHE are monoclonal and thus representing metastatic instance of the same clone rather than field effect. Okay, thank you. This is a 72-year-old male, submandibular. This is from 2004. I can't believe you found it.
Kind of what looks like to be like a cystic mass almost. You have like a lining of these cystic areas And then you also have right here that is not really well circumscribed. It's kind of has a lobulated appearance. The lobules, very, they're very scattered. You almost have like a septation right here dividing the lobules from each other. Very, very pink tumor.
Right.
And the lining looks very, this is a true cyst. The lining looks very similar to the cells that are posing these lobules and
Why does it look so pink? What are those cells? Candy?
Look like it's juicy or
Cute.
Cytoplasmal granular.
so the nuclei are pretty monotonous. They have these like nucleoli that are staring back at you.
Yeah.
Some of them have peripherally located nuclei, some of them have centrally located nuclei. They kind of fit together like a jigsaw puzzle. The nuclear membranes are some pretty well defined, actually. You can see them pretty well. With that being said, I don't know the this.
Okay, so let's think about that. So you've already picked out one characteristic feature, which is these very round monotonous nuclei with nucleoli that are staring back at you. And then put that in the context of the cytoplasm. It's abundant and pink and arguably granular.
Granular cells.
So not quite. In salivary gland and thyroid gland and in parathyroid, in kidney. What granular eosinophilic cytoplasm and round nuclei with pounded nucleoli? Those are oncocytes. Exactly. So those are oncocytes. So this is sheets. This is chock full of oncocytes. Okay. So that's part one. What are options for oncocytic lesions of the salivary gland? Cytoma, Warthin tumor. Mhm. Hyperplasia of the elderly. This guy's a 72-year-old. So, all right, so keep that all in your mind. Most importantly, at the time of frozen, what do you want to tell them? That this is benign, malignant, low grade, high grade, just whether or not, whatever the diagnosis is right now doesn't matter. What do you want to tell them at the time of frozen?
It's, I think regardless of what it is, it's either benign or low grade.
Great, right? So we don't have any smack you over the head, like this is a high grade malignancy that you need to do a neck dissection for, right? So at the time of frozen, that is the most appropriate answer. At the time of permanent, then you have to decide what this is. So let's take, yeah, that's a good one. We already know it's oncocytic. We already have a differential diagnosis of oncocytic lesions, which are a benign oncocytoma, which are theoretically, you can have an oncocytic carcinoma. Theoretically, you could have a Warthin tumor, but as mentioned, this is very lymphoid poor, so we're not necessarily thinking about a Warthin tumor. And then in elderly patients, there's this, 70s, 80s, there's this thing called nodular oncocytic hyperplasia that can happen. in which you get multiple small foci of oncocytic proliferations throughout the gland, some of which may sort of develop into these larger dominant oncocytic nodules that are arguably more like oncocytomas arising in a background of nodular oncocytic hyperplasia. So this is all a potential spectrum of what one might see for oncocytic lesions.
Sorry, this is cholesterol
Mhm.
or is this biopsy?
Could have been, yeah, probably. Got fibrosis, hemosiderin, cholesterol probably was biopsy site.
Where's the frozen? Like it's nicely encapsulated.
Yep. The low grade, still circumscribed. Okay, so it's. Yeah, so the other thing that I didn't mention, which you can get is in oncocytic lesions, is an oncocytic mucoepidermoid carcinoma. Which in that case, it may be solid, it may be cystic. You want to look really hard for mucocytes. You know, the good thing about all these salivary gland neoplasms, right, is as long as it's low grade, honestly, the clinical treatment isn't going to change, right? So if it's a low grade oncocytic mucoep or a low grade benign oncocytoma, like honestly, the patients aren't going to be treated that much differently other than observation. So genetics can help. We are now discovering, as we said earlier, very specific genetics in a lot of these salivary gland neoplasms, right? And so if you were to consider an oncocytic mucoepidermoid carcinoma, for example, even though I don't think that's on the differential here because I don't see any mucocytes, what genetic rearrangement do we find in those? CRTC 1 or 3 with mammal 2, all right. In oncocytomas, there's really no genetics that we know of, so that's helpful in and of itself. But yeah, so this is just a benign oncocytoma, and you'd have to look at the background. I don't know, did this have oncocytic hyperplasia in the background? I don't remember. I don't think it did. You'd have to find, maybe we can find an example of that next time, but yeah, so if you were to call this a dominant, oncocytic thing arising in a background of oncocytic hyperplasia, you'd want to see little like oncocytic foci in the background parenchyma, which we don't have. Thank you.
Between like very florid acidic metaplasia.
Yeah, so if it's a dominant mass forming lesion and they're taking it out for that reason, I'd probably err on calling it a site of an oncocytoma, but to call something a neoplasm, you'd have to know that it's clonal. And unless you do clonal analysis, you're not going to know. So you're just going to have to take your best guess, right? And so you can call it a benign dominant oncocytic lesion arising in the background of multifocal nodular oncocytic hyperplasia, or you can just call it an oncocytoma arising in the background of nodular oncocytic hyperplasia if they're taking it out because it's a problematic mass forming lesion, right? And so there's no good, there's no cutoff, there's no good answer. It's just a matter of clinical setting, and truly to determine if it's neoplastic, you'd have to do clonality. Versus, is it just a florid hyperplastic singular in the background of multiple others? I don't know. No, absolutely not. Absolutely not. But I think that the easiest thing to do for verbiage is just oncocytoma in the background of hyperplasia. it's the same problem with thyroid, same problem with adenomatous nodules in the thyroid. You don't really know if they're truly clonal neoplasms, adenomas, or hyperplasias, or adenoma arising in the setting of hyperplasia when you don't have clonality, right? So, or a mutation, right? But thankfully, follow-up is not any different. Yes, ma'am.
Probably don't, but, every time I see like granules, it's something salivary, I think of like acidic cell.
Okay,
So then I guess if I really wanted to differentiate, because I don't know much about oncocytoma,
Yeah.
I guess what would just dog one and
all right,
what
come
would,
here.
oh,
You asked, I won't, let's do case 11. Yeah, but now, I mean, it's, everyone's gonna learn. There's a few there's H&E differences and then there's immunohistochemical differences, but first let's talk about the H&E differences.
alright, so I mean, what I have so far, it looks fragmented, there's nothing, no capsule, no normal around it, but yeah, even already, I guess I'm kind of seeing that this is more basophilic than
Mhm.
eosinophilic.
Yep.
And these cells do have like a granular, almost like frothy looking cytoplasm, and the nuclei, yeah, they're smaller and they don't really have nucleoli.
Yeah, so I think that there are two main differences that you've already pointed out. One is in the nuclei. So acidic nuclei are smaller without the nucleoli. And cytoplasm is more purple granules as opposed to pink granules, right? Because these are zymogen. And so if you were to do a PAS diastase, yeah, that might help you. But if H&E doesn't help you, maybe PAS can help you. So this is PAS and PAS diastase, yep, from the oncocytic thing. So just peek at those. So remember, PAS will stain PAS will stain glycogen, PAS will stain zymogen, and diastase will digest out the glycogen and will not digest out the zymogen. But this isn't even picking up anything because it doesn't pick up mitochondria, right? So even on the plain old PAS #1, you're not even getting much in the way of I mean, maybe there's a couple gloppy glops, right? But if you were to, do we have a PAS on the acidic? If you were to throw a PAS on the acidic with a PAS diastase, I mean, it would be like every single zymogen granule would pick up, right? As opposed to in the oncocytic thing where the mitochondria really are not picking up because they're neither glycogen nor mucin, right? Neither glycogen nor mucin nor zymogen. So mucin and zymogen are diastase resistant, right? Glycogen is diastase sensitive.
This is with the diastase.
This is with diastase, right? But it doesn't make too much of a difference if you didn't really have it to begin with, right? You mentioned dog-1. So yes, dog-1 stains the apical borders of the cells of the cynic. I've only found it helpful in a few circumstances because it can be really focal and patchy and it's not really a strong, bright, vibrant stain. It's kind of like, oh, there's a little, it's like a curvilinear, like membrane staining with dog-1. It's like a little bit of a curvilinear stain on like the apical membrane. Like it's really subtle sometimes in a cynic. But we've seen it be helpful on cytology actually, where they have like a few cells and they have a cell block, and like, if you look at it, you can look at it and say acidic, but if you're not sure, you can throw a dog one on, and if you see a little bit of a wisp of a corner staining, it could support your diagnosis of acidic, but honestly, I think PAS and PAS diastase are helpful. So acidic is one of the few carcinomas, low-grade carcinomas, that actually is often circumscribed, right? So you can see that there's a border, there's even maybe a capsule. The question is, do we call these, you might look at it, you might say, why isn't this an acinic celloma, right? Why isn't this an acinoroma? I don't know, it's not, it's just an acinic cell carcinoma. But these are more often than not low grade and circumscribed, but you can see the nice, beautiful purpleness of the granules and the smallness of the nuclei. So is that a good side by side for you? Yes. Good.
This is called the cynic cell, but then didn't they change the pancreas name because it was too, is it like acinar cell now? Because they thought of, people kept getting confused.
Still get confused.
What-
Yeah, pancreas is
Pancreas is acinar.
Okay, but it's like, but it
This
looks
is
the same.
acid.
Okay.
And we don't use the digestive enzyme stains in this because I don't think they work as well as they do in the pancreas. What do you guys use? Like trypsin, chymotrypsin? Yeah, I don't think those stain very uniformly salivary. I think that the digestive enzymes are different. So yes, not acinar, acinic. Mhm. Well, it's 9. Is this format helpful for the salivary tumor? Should we keep going next time? Okay.
Yes.
Yes.
Oh, yeah, yay! Cool, we have a bunch of cases left, so we'll do the same next session. And in the meantime, review my didactics if you want on YouTube for more formal lectures. Comments, questions? Cool.